Good evening, ladies and gentlemen. Welcome to the 15th Annual Academic Sessions of the Sri Lankan Orthopaedic Association for the year 2023. The Sri Lanka Orthopaedic Association, after another very successful academic year, has once again reached its most anticipated and the most colorful event of the year. The theme for this year's academic sessions is Stability and Growth in Uncertain Times. To start off today's proceedings, I would like to invite all of you to please rise for the arrival of the chief guest and the guest of honor. Ladies and gentlemen, please rise for the arrival of the chief guest and the guest of honor. Ladies and gentlemen, you are now witnessing the arrival of our chief guest, Professor S. Rajasegara. He is accompanied by our guest of honor for tonight, Dr. G.L. Puncheheva, and Dr. Dilshan Munidasa, our distinguished orator, Honorable President of SLOA, Dr. Bandhujiva Piyasena, along with the rest of the office bearers and the council members of the SLOA.
To begin the ceremony of the evening, let us rise for the national anthem of Sri Lanka. Thank you. And now, I would like to invite the following dignitaries to light up the traditional oil lamp to mark up the ceremonial beginning. Dr. Bandhujiva Piyasena, the President of Sri Lanka Orthopaedic Association, Professor S. Rajasekaran, the Chief Guest for today's ceremony, Dr. G. L. Punchiheva, our Guest of Honor, Dr. Dilshan Munidasa, the orator for the year 2023 SLOA oration, Dr. Hiran Amarasekara, President-elect of SLOA for the year 2024, Dr. K. Upali Banagala, representing the Council and the senior orthopedic surgeons, Dr. Jayakumar Janardhanan, Treasurer of SLOA, and Dr. Indika Veerasinghe, the Secretary of SLOA. Thank you. And I would like to invite Professor S. Rajasekaran, our chief guest, Dr. G. L. Punchuheva, the guest of honor, Dr. Dilshan Munidasa, this year's orator, and Dr. Bandhujiva Piyasena, President of Sri Lanka Orthopaedic Association, and Dr. Indika Veerasinghe, Secretary of SLOA, to take their seats at the head table.
Ladies and gentlemen, please be seated. Now, it is my honor to invite Dr. Bandhujiva Piyasena, President of the Sri Lanka Orthopaedic Association, to deliver the presidential address.
Professor S. Rajasekaran, the chief guest tonight, Dr. G. L. Punchuheva, our guest of honor, Dr. Dilshan Munidasa, SLO Orator 2023, and the immediate past president, Dr. Indika Veerasinghe, the Secretary SLOA, Dr. Jayakumar, the Treasurer, distinguished overseas guests, honorary past presidents, members of the Council, Professor Janaki Heva Vicente, and the family members of late Dr. Pradeep Fernando, my dear teachers, colleagues, friends, ladies and gentlemen, good evening. On behalf of Sri Lanka Orthopaedic Association, I warmly welcome all of you to the inauguration of Annual Academic Sessions 2023. On this pleasant evening, first and foremost, I would like to thank the members of SLOA for entrusting me and my council with the responsibility of leading the association in 2023. The year 2023 dawned with a lot of challenges due to socio-economic crisis that prevailed in the country. That made us think, as an association, how we could rise from the difficulties and improve our regular educational activities while contributing to the orthopedic care in our country at large. As the circumstances suggested, a fitting theme, stability and growth in uncertain times, was agreed upon, and the goals were set to work towards. Looking back at the history, the Sri Lanka Orthopaedic Association was started in 1992 with less than 10 members, and over the years it has expanded to its current strength of more than 100 members. During the founding days, only 8 major hospitals in the country were manned by the orthopedic surgeons, whereas the basic fractures in other hospitals were managed by our general surgeons. As the number of orthopedic surgeons gradually increased, more orthopedic units were opened up in all major hospitals, namely teaching, provincial, and district general hospitals, thus achieving an island-wide coverage. By now, there are about 70 orthopedic surgeons working in 37 government hospitals and around 20 providing their services in the private sector. Therefore, today, almost all the orthopedic patients seeking treatment in the hospitals are managed by us, ensuring a better outcome. In addition, there are about 70 doctors in postgraduate orthopedic training, awaiting to become consultants within next 6 years. As a professional body, one of the main objectives of SLOA is to nurture and educate the aspiring surgeons who will shape the future orthopedics in our country. To achieve this goal, SLOA organized a variety of lectures and practical courses in collaboration with other esteemed societies. The SLOA conducted basic arthroplasty sawbone workshops on hip and knees with the support of Arthroplasty Society of Sri Lanka. They provided opportunities to learn practical aspects of these procedures. Similarly, external fixator workshop held in Kandy was a great opportunity to learn skills and techniques of this useful procedure. Moreover, the SLOA continued its tradition of hosting the Ponseti Clubfoot Management course at LRH, which has been instrumental in improving quality of life in many children with this condition. The SLOA also arranged 4 live surgery sessions to enhance the knowledge and the skills of practicing surgeons. In January, the Colombo Shoulder Meeting featured live surgery on shoulder arthroplasty and stabilization. This exciting and inspiring event set the tone for a dynamic calendar year of events. Pediatric hip preservation live surgical demonstration was a rare and valuable opportunity to witness. The surgeons in the audience were impressed by the quality and professionalism of the course. The live surgery session on complex primary and revision hip arthroplasty was a highly successful event that required a lot of resources and coordination to make it a reality. Demonstration of hip arthroplasty through anterior approach was a testament to the progress that SLOA strives to achieve in order to keep up with the current world trends. SLOA achieved a remarkable feat by conducting 3 cadaver workshops within this year. These workshops were the results of months of careful planning, relentless perseverance, and unwavering support from various parties. The anatomy departments of Sri Javadnapura and Colombo medical faculties played a vital role in providing the cadavers of suitable condition. Amidst all these constraints, SLOA was able to organize the cadaveric arthroscopy workshop for the first time in the country with such unparalleled high standard. This novel task was accomplished under the guidance of well-experienced foreign and local faculty, and it was a joint effort with the Anuradhapura Clinical Society. The Colombo Cadaveric Spine Workshop, held for the 2nd successive year, was very comprehensive, and it was customized to the needs of the participants. The pre-Congress Hand and Wrist Cadaver Workshop was held in collaboration with the Hand Society, and it was multifaceted, and it is a need of the hour. The SLOA strongly believes that establishing a cadaveric bioskills lab, is a necessity and a goal that it should actively work for. Such a lab would enable more cadaver workshops to be conducted in the future, offering a golden opportunity for enhancing skills and knowledge in various procedures. The Colombo Trauma course was a joint effort by SLOA and Trauma Secretariat at NHSL to educate middle grade doctors on common orthopedic trauma. We held 3 fracture management courses in collaboration with the AO Alliance for the benefit of doctors and ORPs. It dealt with non-operative as well as basic fracture management. These courses and workshops were truly remarkable occasions where the young surgeons and the trainees could learn from the highly knowledgeable faculty members who showed their passion and commitment to advancing field of orthopedics in Sri Lanka. SLO is thankful to all the faculty members, both local and foreign, who contributed to these successes. We continued with the tradition of Young Surgeons Forum by the newly qualified surgeons who shared the most updated foreign experiences with their colleagues. The team of young surgeons represented SLOA in the symposium on pelvic trauma in the annual surgical congress in 2023. The guest lectures on scoliosis, walking age DDH, and musculoskeletal oncology were invaluable educational opportunities provided to the membership in 2023. The outreach educational program held in Monragala strengthened the orthopedic knowledge and practice among the doctors and nurses in the periphery. While engaging in plethora of educational activities, SLO members did not forget to enjoy life together with their families. This year, we organized a New Year celebration day in April for the first time, where orthopedic surgeons' wives played a leading role. This was truly an enjoyable time for surgeons and their families alike. Scientific research and publications should be a part and parcel of a professional career, though it is frequently overlooked in our setup. The lack of frequent stimulation to develop research skills may have partly contributed to this. Therefore, SLAO conducted a research and publication workshop for the second successive year with experts from the field of research, statistics, and library sciences. Several online discussions were also held for the postgraduate trainees to address their problems in this regard. Yet there is a significant room for improvement, and SLOA will have to adopt new strategies such as arranging competitions and rewards in order to achieve this. It's with great pleasure that I mention the Sri Lankan Journal of Orthopaedic Surgery. The official publication of SLOA on research is due to release its 9th volume parallel to the annual sessions, thanks to the editor and contributors. Further, it is scheduled to go online from this volume onwards, providing easy access locally as well as internationally. As orthopedic surgeons, we do understand jack of all trades will not be practical anymore in modern era of rapidly expanding knowledge. Discussion on developing subspecialties has been a hot topic among orthopedic surgeons in our country for the past many years. But I am glad to note it has reached a consensus by now. The Board of Study in Orthopedics has proposed 7 subspecialties to the PGIM for its approval. Along the same lines, SLOA has recommended to the Ministry of Health to create subspecialty posts in the main centers in the latest card projection proposal. If these positions are advertised before the availability of board-certified subspecialty consultants, I hope only the persons with adequate background and moral obligation to do the justice to such posts would take them up. The concept of forming subspecialty societies under the umbrella of SLOA was initiated last year. This year too, we were able to launch 2 societies, Sri Lanka Arthroscopy Society and the Sri Lanka Pediatric Orthopedic Society. Now, this provides a common platform for those who have the same interest to share their knowledge and experience. These can function as a central point for planning future strategies for the betterment of the relevant field in collaboration with the Mother Association. Amidst all these, I wish to bring your attention to some issues that we are faced with, which emerge with the COVID pandemic, but are extending due to the socio-economic crisis. The impact of these things are more on orthopedics, as we are one of the subspecialties that is highly dependent on technology. The impact has been on two fronts. Number one, there has been a wave of migration of highly skilled and educated individuals seeking their fortunes in the greener pastures. We are witnessing the outflow of consultants, middle-grade doctors, and supporting staff. Number two, due to restriction in foreign currency and devaluation of the rupee, we are facing with severe shortage of implants and supporting ancillary equipment. While we understand the major policy interventions that are necessary to correct them is beyond our scope, one way of potentially transforming this crisis into an opportunity is to develop a series of collaboration with individuals and professional networks between the source and destination countries with a view to promote knowledge and skills transfer. More flexibility in the regulations for the board-certified consultants and even the middle-grade doctors to work in the country periodically may be required in the future to bridge the human resource gap, as is done in some developed countries. The other is to develop sustainable solution for our shortage of implants. That can be done by developing our own capacity to produce low-cost but high-quality implants locally. This requires synergy among academic and technical industrial sectors, where the Ministry of Health has a pivotal role to play. As end users, we orthopedic surgeons should be eager to push for these things in order to realize this dream. Coming back to our annual sessions, we started today with an exciting event, Born on Bikes. The cycle parade organized by the Sri Lanka Orthopaedic Association, joined by about 100 enthusiastic cyclists. This event was a symbolic gesture to launch a bone cancer fund, a noble initiative to help bone cancer patients who cannot afford expensive tumor prosthesis. We hope this colorful event will inspire the whole country to support this worthy cause. The annual academic sessions will start tomorrow with the participation of a renowned foreign faculty. They will join hands with our eminent local faculty to enlighten us with the current practices and emerging trends in different fields of orthopedics. I wish the knowledge acquired, experience gathered, bonds created during this academic event will last long and will be used for the upliftment of orthopedic care in our country. As I finish my tenure as a president of SLOA, I would like to express my sincere gratitude and appreciation for your support and cooperation. It has been an honor and a privilege to work with such a dedicated, generous, and a united group of people who are eager to create opportunities to acquire knowledge and experience. I'm extremely proud of what we have achieved together in the past year. We have been able to promote the advancement of our field and foster professional development through our work. We have also strengthened our network and collaborations with similar professionals and institutions internationally. We have no doubt our association will reach greater heights in time to come under the leadership of new president and new council. I would like to specially thank one person. That is our secretary, Dr. Indika Veerasinghe, for the enormous amount of hard work done with total responsibility and full dedication, not only in organizing these annual sessions of this magnitude, but also in multitude of activities carried out throughout the year. I'm extremely fortunate to have him as a secretary. Finally, I want to express my deepest gratitude to my family for being my pillar of strength throughout this journey. I wish annual academic sessions all the success. Thank you.
Thank you very much, sir. It was indeed a mesmerizing recap of the all academic and non-academic events organized by Sri Lanka Orthopaedic Association during this year. And now, I would like to invite Dr. Bandhujiva Piyasena, the President of Sri Lanka Orthopaedic Association, to introduce today's chief guest, Professor S. Rajasekaran.
On behalf of Sri Lanka Orthopaedic Association, it's a great honor to introduce Professor S. Rajasekaran, MS Orthopedics, FRCS Edinburgh, MCH, PhD, and the Honorary Fellow of the Royal College of Surgeons of England. Professor S. Rajasekaran has held many leadership positions in orthopedics and spine surgery, in his own country as well as internationally. Notably, he was the president of Association of Spine Surgeons of India for 4 years, from 2008 to 2012, and the president of Indian Orthopaedic Association from 2011 to 2012. He was the president of World Orthopaedic Concern UK from 2005 to 2007. He was the chair of AO Spine International Research Commission from 2015 to 2017. And then he was the chair of AO Spine International Board from 2018 to 2020, before taking up the position of President, Asia Pacific Spine Society from 2021 to 2022. Professor Rajasekaran has spent a lifetime in research, during which he has been a recipient of multitude of accolades. Of significance, he received the North American Spine Society and Society Outstanding Research Award consecutively for 4 years, from 2019 to 2022, and also the ISSLS Prize for the Best Spine Research for 5 years. In the year 2019, he received the Best Clinical Research and the Best Basic Science Research Award from Asia Pacific Spine Society. In the same year, he received the Best Clinical Paper and the Best Basic Science Paper Award from the Asia Pacific Spine Journal. In 2021, he was the recipient of Best Presentation Award Infection category from Asia Pacific Orthopaedic Association. This list of awards is by no means even close to being complete. But before I move on, I should mention that Professor Rajasekaran has been a consistent recipient of research and publication awards from 2003 to 2020 from the Association of Spine Surgeons of India. In the field of publications, he is the deputy editor of JBJ's Journal of Spine and Global Spine of the USA, and the deputy editor of the Journal of Craniovertebral Surgery and Spine. Continuing on, he was recognized as the distinguished visitor to Harvard Medical International, Boston, USA, and Grand Rounds lecturer of Dartmouth University and Mayo Hospital, USA. He was named the Hunterian Professor for the year 2011 and 12 by the Royal College of Surgeons of England. He is the Adjunct Professor of Orthopedic Surgery, Tamil Nadu, Dr. MGR Medical University, and currently is a member of Board of Studies of Bharatiya University. He has made over 500 publications internationally and nationally. He has over 500 publications in peer-reviewed journals. He has contributed to over 75 chapters in international books. And he is the chief editor of a video atlas of spine surgery and ASSI textbook on spinal infections and trauma. Presently, Professor S. Rajsekharan is the chairman of the Department of Orthopedics, Trauma and Spine Surgery at Ganga Hospital, Coimbatore, India, which is currently the largest orthopedic subspecialty hospital in South Asia. May I cordially invite Professor S. Rajsekharan to deliver his address as a chief guest.
Distinguished President and Secretary of the Sri Lankan Orthopaedic Association, learned council members of the association, international faculty members, members of the Sri Lankan Orthopaedic Association, family members, ladies and gentlemen. At the outset, I should thank all the members of the society and the President and the Secretary in particular for giving me this honor, a great privilege indeed. India and Sri Lanka are closely intertwined because of the neighboring geography, but also a lot in culturally, in cuisine, in language, and also thickly woven in history. And it is always a great pleasure, a happiness to be here. Thank you for this invitation. So when they asked me to talk of something different from orthopedics, I just chose the topic of how much we can contribute richly to the scientific content of the world. Because this is a big question mark in the minds of the young surgeons world over. We know the buzzword now is globalization. I mean, the world has become a global village. No longer can any one of us in any part of the world live insular. Because what happens in one part of the world immediately, without a lag, is known to the rest of the world and also affects to a great extent the happiness and living of everyone there. This is not only in politics, it is not only in society, but also in the scientific world. Last year, there was a notification from the Mayo Hospital that probably they have found a cure to spinal cord injured patients. And the next day, we had a whole lot of patients from every single village around Coimbatore coming into the hospital and asking, can we have the same treatment? Can we, who have been paraplegic for so many years, be made to walk? And this is just in 24 hours across the globe. And so, now what is important now is not wealth or anything, but the new power equation is knowledge. And whoever creates knowledge is going to be the future leader. And knowledge creation is going to crown the people. But knowledge creation doesn't come easy. I mean, it is very difficult. And it also requires a huge infrastructure and also a large amount of research fund. And here comes the big difficulty. When you look at the expenditures on R&D across the world, you will find that there is a huge difference. The United States standing tall and first with 660 billion US dollars. And when you come down, you find that it comes down and down. I just found Sri Lanka, but Sri Lanka is a very small country, and so this is really understandable. But the difference between the developing world and the developed worlds in their contribution to research is extremely different. Not taking one country, but all the countries of SAARC put together, the budget is still a very minuscule. And if we put the whole of the advanced Western developed world, it is just a drop in the ocean of what we developing countries can manage. And this looks exactly like this. I mean, there is a big difference in the power, in the amount of money that is available, in the amount of infrastructure that is available, and in the research support that is available. And this can be really upsetting to the young surgeon's mind. So there is a lot of relevant questions that come around. Do developing countries have any relevance in the scientific world now or in the future? Because the gap can sometimes be really widening. Can we contribute something useful? Or should we have a separate existence, or we all should merge with greater organizations? And do we have a chance to score over the developed nations? And I think if I have to consider algorithm, then I think we should go to this simple story of David and Goliath, which we learned when we were in school. Now, all of us know this story, but for those who don't, the Philistines and King Saul were in constant fight with each other. And in the Philistine army, there was a giant, Goliath, who was 9 feet tall. Probably he suffered from growth hormone disturbance because he was 9 feet tall. And nobody dared to challenge him. So he came to King Saul and challenged him for a direct fight, or at least one of his representatives. And no one in King Saul's army would dare to do it. And in the last minute, surprise, surprise, the offer came from a shepherd, a young shepherd boy, who was used to protecting his young lamb from the wild animals. And he was an extremely good with his catapult, and he was able to throw stones very accurately from a distance. And that was his strength. And when he offered, Goliath was so angry to see that King Saul had just sent a small boy. He was so furious, and when he came close, as far as he could come, then David hit him with a stone on his forehead, which actually knocked him down, and that was the end of the story. Now, this is not just a story. I think this is always compared to life situations where a small, weaker, but innovative person is pitted against the larger, more stronger, and seemingly overpowering person. So I think we can draw this according between the SAARC countries, developing and struggling always with the economy and with infrastructure, and against the well-developed nations, and how much can we match in our scientific input towards each other. So here we should think, what gave David his victory? First of all, he did not lose his self-esteem. I think this is one of the most important things that all of us have to get over. He was not afraid. He was not awed by the size and magnitude of his adversary. He knew his strength, that he could attack the other person from a distance, whereas David has to get near to the enemy to use his blows. And he did not hate his foe. All the other kings' armor and sword, when it was offered to him, he did not take it. And he decided to come on his own terms. He knew his strength and he used it to his advantage. And so, the most important story that we should know about is that we should not lose our self-esteem. We should not suffer from a cultural shame. And the trick is not in imitating and competing with the strength of the developed nations, but to find our true strength. Now, this will actually mean the most important things. Now, because we may not be able to do an RNA metabolism research, that's not the only research that is possible. More important, there is something what is called the clinical science. And here, we have the biggest advantage and we should be used. So we should not be attracted to the latest, costliest, and the most interventional method of treatment in anything. And in fact, we cannot afford to follow or imitate the West. Mainly because, if you see here, the healthcare expenditure in the West is so alarmingly rising, that if we adopt the same treatment methods, we would go bankrupt. It is impossible for us because developing nations, we have 70% of the world population and 80% of the disease burden in the world. And if you take something as important, what we see in day-to-day life, like the low back pain and disc degeneration, which accounts for more than 85% of the low back pain. The modern world and scientists, I am a spine surgeon, so I am thickly into this conspiracy. So there is nothing that we have not done to the disc. We have tried magnetotherapy, electrotherapy, we have tried different kinds of injections, we have tried all kinds of waves, we have directly put electrodes into and burned the disc, we have put enzymes into them, we have tried to suck them, we have put many different kinds of growth hormones. And if you look at the last 8 years literature, there are more than 21 types of different interventions that we have done. And sadly, the outcome of most of this is no better than conservative treatment. But they are all at least 100 times more expensive than the conservative treatment. So we cannot afford to go on the same lines as what is possible in the West. Secondly, most obvious thing is that our disease burden is different. Everything between us is completely different. So if you look at these two ladies, there is nothing that is common between them, isn't it? Their affordability is different, their expectations are different, their lifestyle is different, the infrastructure that is available for them is different, the cost provider is different, there is insurance for one and there is no insurance for the other, there is a social security for one and there is nothing for the other. So when everything is different between these two, the solution alone cannot be the same. For the same problem, the solution has to be definitely different. Otherwise, we may be forced to enter into this big pit. This is one of the things I saw a few months before, a 34-year-old male, paresthesia of forearm, short duration. This is a classic case where there is no neurology and he has to be treated conservatively. But unfortunately, had a 3-level disc replacement. And this is not actually the good treatment for he became a neurological deficit. Again, another surgery was done, which left him over there. So we need to be sure of what we are doing to our patients because that there is a total difference of affordability and lifetime realities between these two. Many other conceptual changes are also there because most practices are insurance based. And sometimes when the insurance takes charge of the practice of medicine, the patient can actually be sent to the sidelines. Now, I was presenting an important paper in one of the leading countries, United States actually to say, and my whole topic was on salvage of these very badly mangled extremities. And to my surprise, at the end of it, the moderator actually said that he was not sure whether this is possible because this will not be supported by insurance clearance for multi-stage surgeries and prolonged outcome because there is scientific evidence that the cost-benefit ratio of salvage these limbs is not that good against doing an amputation and giving a high-quality prosthesis. So it just was like a slap on my face to know what is the reality between the West and the East. In our country, it makes a huge difference to salvage and give back the limb to these patients because their lifestyle in the village and in the rural areas is completely different and their affordability of high-class prosthesis is not possible and the maintenance of a high-class prosthesis is as expensive as a major surgery. So when we look at all these evidence-based medicines, it is very important to know that there could be a real difference in what is the characteristic, what is the baseline of evidence that we are actually seeing? For example, if you look at the cost between a cervical fusion and a cervical disc replacement, it is at least 4 times more, the prosthesis. But the difference is that it gives a 3 degrees to 4 degrees more range of movement when you measure it on the radiology. Now, does this matter to the patient at all? I mean, these we have to look at the background of what is our this thing. One of the other most important things about which I have been talking about huge, and this was the topic of my presidential lecture in the ISILS in Amsterdam, was that as young surgeons, we need to be really careful that everything that is published is not Bible truth. Now, you'll be surprised in PLOS 1, that is a paper, how many scientists fabricate and falsify research? A systematic review and meta-analysis of survey data. And here you find that almost 39% of scientists felt that they know of another research in their institution which was not 100% perfect in science. So this actually makes it another problem, because industry, and they found that the whole difference is huge between self-funded research and industry-funded research. Because now industry talks through the tongue and writes with the hands of famous medical men, and we need to be really careful about it. I'm not sure how many of you have actually went through this, because it was recently revealed that for us, Harrison's textbook of medicine is the biblical truth. And it was revealed that some of the very most important chapters on cardiovascular medicine, some of the authors had not written the chapter. They had only a cursory look because it was written by somebody else. And this we need to be really careful, because this all comes to a picture where there is a gray science that comes back as evidence when it is actually goes into print. Now, all these we all know, there is a huge amount of consultant fees that goes into many of these research. You might have seen, it's all on the net, and there is nothing new in what I'm saying. And in the field of spine, one of the biggest problems was the story of steroids. Steroid was advocated to be given to every spinal cord injured patient, and in a very high dosage, at a dosage which was many times higher than it is given for any other type of disease in human diseases. And this was actually perpetuated not in small journals, but you can see it is in JAMA. The impact factor of JAMA is nearly 56 or something. The New England Journal of Medicine, which is 75. And all these were perpetuated. Now, this came after the first bulletin of that steroids must be given actually was not in a medical journal, but the people first released it in New York Times. So it came as a public knowledge first, and this was sent as a fax to many of the hospitals. And then 19,000 fax were sent to all emergency departments. And then it became a medical legal issue if you are not using steroids. But later, 3 well-done clinical trials, 6 cohort studies, 12 larger animal publications were studied, and they found that there was no difference between giving steroids and no steroids. But what happened was, because of the highest dose of steroids, the incidence of infection and death due to pulmonary infections and due to bleeding was 6 times higher. But by the time, billions of dollars worth of Solumedrol had already been sold. So you have to be really careful about what is coming into the research and where from it is coming. This was the same thing that happened in BMP. And Eugene Carnegie, the chief editor of the Spine Journal, actually also wrote about how some of the trials done for BMP were not of the gold standard. And many of these side effects, including carcinogenicity, was not reported in these trials. And so he said in his editorial, the Spine Journal calls for end to years of living dangerously. And he also purported that many of the people, very famous surgeons, had been paid huge monies for what they had participated on the BMP trials. So this all actually goes to prove that many of the trials which are coming out in the best of the journals are also sometimes not really true. So that is one of the most important reasons why we have to stand on our own feet. Because innovation flops, I mean, we cannot afford to have an innovation flop in a poor person. Because 9 out of 10 products fail. And when they fail, these are the people who cannot afford it. I mean, our people come with neglected injuries, they come with neglected deformities, and the primary reason why they have come neglected is because of inaffordability. They cannot be used for clinical trials or to test experimental modalities. Every day for me, and I'm sure it's in every surgeon in Sri Lanka, that we see lots of patients like this. And one of the things that we do every day is to place a price on the health and well-being of a fellow citizen. I mean, we have to quote a price. And it is very important that we do a medicine which is affordable to everybody. Because for us, we have special needs. Not the latest technology, not the cutting edge technology, not an equipment which is just 0.1% better than the previous version. But we need to do cost-effective medicine. We need to do appropriate clinical medicine. Prevention of complications must be foremost, and we need to do and concentrate on preventive medicine. So if that is the strength, and this is our equation, then what will be our winning strength? How should we go in? So what is going to be our stones? And this, I think we need to be very careful about what will be our winning strengths. That there is no money for research is also a big thing for us, because there is also no money in research for us. I think you have to be really careful about this. There is no money in research, and so what comes out of the research in the developing countries will be pure research. We always thought that we had no time, our population is too big, we have too many patients to take care of, and where is the time to do research? Actually, it's only a mindset that will make it a difference. Our in India, our economy is booming because what was considered to be a big underdog or a big disadvantage for India, that we had 1.2, now it is 1.4 and it is ever growing. That we thought it to be a disadvantage actually was converted to an advantage, because 550 million youth were there, there was a purchase power and other things. So if we can convert this huge population into a clinical analytical strength, I mean, that will be the biggest thing that we can actually do. And the only thing that is required to do this is not a big laboratory, it's not $1 million infrastructure, you don't need the proteomics, next genome sequencing, you don't need metabolomics, you don't need RNA transcriptomics, studies and all that. We need to change ourselves from surgeons to surgeon scientists. We have to become a clinical scientist, and we don't need to do rocket science research. And this is what I exactly mean, that we should not get belittled by reading many of these big journals where they are looking at RNA transcriptase levels, difference between people who have rifampicin sensitivity and rifampicin resistance. You know, that really puts a block into it. Where the hell I am going to do this kind of research? It's not necessary to do that kind of research, but there is so much more that we can do, because clinical research is also very, very invaluable. Just take one simple example. I apologize for putting all these spine things on you, but something as simple as a burst fracture of the thoracolumbar spine, which is one of the most commonest. There are still 100 questions which are not very clear and answered very clearly. Because most of the industry-sponsored literature that has been published, more than 90% of the literature is on some aspect of surgical treatment. But even before going into the discussion of whether posterior approach is better or anterior approach is better, the part or the great contribution of the developing world will be to ask, is a surgery required at all? that will take you to the real basic structure, which will empower you to do what is right for the patient. Now, for a patient like this, where there is a 50% decrease in the body height, no question it will be treated in most of the places. But this is a person who is a hard-working individual. 3 years post-follow-up is absolutely normal. So the questions we have to ask is one step even far ahead of what the Western world is asking on. What are the individual steps? What biomaterial is required? What is required? We have to ask the fundamental question, is surgery required at all? If then clearly defined principles and indications, which will be really good. For a long time, we thought that canal compromise, even to 25 to 40 degrees, is an important need for surgery. But there are people who have very well reported that spinal canal remodels with time, and there is absolutely no need for doing this. And also, it was very well reported in literature. We thought it is absolutely must that when you have a canal compromise like this, you should do a anterior surgery. There are many papers which say the best way to do is to do a posterior and anterior, and then there is a huge amount of literature. Would you do an anterior open, mini open, laparoscopic, or something? The controversy comes into the nitty-gritty of the surgery. But, if you step one step behind, you can ask the fundamental question, saying the same thing we achieved by just a posterior surgery by proper contouring of the rods, and you can see that the spinal canal is decompressed. Or you can even say when there is a load sharing classification of more than 7, even then that an anterior surgery is not anterior surgery, which in an acute setting is very expensive, very costly, very bleeding, and this is something that the patient goes into an ITU for 2 or 3 days. We have to go into the fundamentals and even think. And so in a large way, developing countries can actually set the indications for not. Now, TB spine must be common in Sri Lanka also, as it is very common in India. As I told you, if you need to do a big time research on resistance, drug resistance, there is a huge amount of infrastructure which is required. But in a child like this, we still don't know one fundamental small question of, does the child need 6 months antituberculous therapy or 9 months antituberculous therapy? And if you go to India, every state treats this child differently. Starting from Chennai and down, where there is a strong group of surgeons only giving 6 months, where if you go up to North India, there are people who are still giving 18 months of chemotherapy. Now, antituberculous therapy is also a little bit of a poison. There are so many complications of giving 3 times more than what is required. And even for fundamental questions like this, clinical randomized controlled trials are not available. Just as much as it is important to do germ and host genome studies on what brings up the resistance, it is also equally important for us to do the clinical trials which will solve many of these questions. So in a larger sense, many of the clinical situations can come from developing countries, and these will be very, very impactful. So rather than, I'm telling the young surgeons here, rather than aiming to become bigger by doing more and more surgeries, you can grow bigger like this, the same but larger. Or you can transform yourself from a caterpillar to butterfly. And that transformation is the important transformation of changing from a surgeon to a surgical scientist. So wherever it is not possible for us to compensate something, that can be compensated by collaboration. Because within Sri Lanka or within Tamil Nadu, there will be institutions which have huge numbers, but they may not have infrastructure. There may be an institution which has infrastructure but not huge numbers. There may be a surgeon who is very good in operating but not good in writing. There may be a surgeon who is very good in research methodology but not so much interested in operating. It just needs all of us to come together, collaborate, to make the combination a very, very winning success. So it will be very important that we overcome our obstacles. There are few role models for research in developing countries. It's not a part of a research curriculum. There is no incentive in our professional standing or progress, and we always think it is a liability for private practice. Where do we have time? I'm so busy in private practice. It is a distraction. We think it is a distraction. And when you're thinking of your day-to-day work, you have to be, the world is moving fast, competition is so high that you have to be really running fast to even remain in the same place. And there are only 100 reasons you can do or give why you are not doing research. The most important thing is we all say that there is no time. All of us are so tired in the evening after having looked at a huge clinic, operated 3 or 4 patients, and then we are so tired. But time is only as we use it. The time is the only thing that is common to all of us. The President of America or the Prime Minister of Modi, nobody can say, I am very busy, I need some more time. Everybody has only 24 hours time. So it's only how we use it that matters. And we all should start with a good clinical audit. If we start, and this is something that we have found very, very useful in our clinic. All our research, clinical research, are based on our clinical audit. Every 3 months when we come with a very critical clinical audit, all the areas where we are not doing well, or all the areas where we are having complications, or all the areas where we think some more knowledge is required, there is a knowledge gap, we take it as a topic for a clinical research. And that is why we have been able to bring out so many impactful papers which have been quoted very much. I am not boastfully, but just to reinforce to the younger surgeons, just by adopting this very simple methodology, we have many international publications where the citations are more than 450. And these are all called the gold, platinum, impactful papers. So not much infrastructure, not much money required. Just a research inquisitive mind, a group of small people who document things very well and who analyze things very well can bring a very good result. So the time has come that we are our own gurus and we need to look at, never mind, you can even compete against Harvard or Stanford or anything. It's just that you need to look at different topics, which is our core strength. We need to look at different methods of research methodology, which is our core strength. We need to look at what we always said, we are too busy to work. We need to convert that busyness, that increased amount of clinical material as our core strength, and then I'm 100% sure that we can far do very well. So we should not have the worry or the cultural shame that we don't have a research infrastructure. We should not try to do research on the same things like biomaterial research or gene research or something. We should do on clinical outcomes, because clinical outcomes, whatever comes out of the lab, ultimately it has to be tested on the bedside. And we can be the ultimate path of testing, of finding it whether whatever came out of the lab is good or not. And we need to know our advantage and we need to do it for our countries. So this equation can be completely different. It just means that we need to be different and we can be a part of the solution for this. So thank you very much for giving me this honor, and I hope that I have carried the message I wanted to carry for the young surgeons over here. Thank you, President, for giving me this honor for being with you here today. Thank you.
Thank you, Professor Rajasekharan, for sharing your wisdom with us and for that inspirational talk. To introduce our distinguished guest of honor for tonight, let me once again cordially invite Dr. Bandujeeva Piyasena, President of SLOA.
Dignitaries at the head table, dear ladies and gentlemen. On behalf of Sri Lanka Orthopaedic Association, it's a privilege for me to introduce our guest of honor. Dr. Gamini Lakshman Puncheva received his primary education at the Government Science College in Matale. He entered the medical faculty in the University of Peradeniya and graduated with MBBS in 1980. Dr. Puncheva completed his internship in Colombo South Teaching Hospital under the renowned General Surgeon Dr. Yogeshwaran, where he developed his interest towards orthopedics. During his post-intern appointments as a medical officer, he gathered a lot of experience in orthopedics, first in the General Hospital Badulla, and thereafter in the orthopedic unit in then General Hospital Colombo under Dr. S.S. Edirivira, the consultant orthopedic surgeon. Dr. Puncheva entered his postgraduate training program in 1991. After completing his local training in orthopedics under Dr. Upali Banagala and Dr. Vasantha Perera, he traveled to United Kingdom for his overseas training. While working at St. George's Hospital in London, he developed an interest in spinal surgery, pediatric and onco-orthopedics. Having obtained FRCS, he returned to Sri Lanka in 1996. He was first appointed as a consultant orthopedic surgeon to North Colombo Teaching Hospital, Ragama, where he converted the existing orthopedic wards into a better equipped, proper orthopedic units. Dr. Puncheva was appointed to National Hospital, Colombo in the latter part of 1996. There he developed a special interest for limb salvaging procedures for bone tumors. He introduced the concept of primary management of open fractures of long bones to orthopedic practice in Sri Lanka. He pioneered the establishment of sports medicine unit at NHSL. After serving at NHSL for 20 years, he retired as the lead surgeon in the accident service and orthopedic department. Dr. Puncheva was a very popular trainer and mentor among postgraduate orthopedic trainees as well as undergraduates. He was a member of Specialty Board of Study for Orthopedics in PGIM and was an examiner for MD Orthopedics and MS Surgery, both in Part 1 and Part 2. He has many scientific publications to his credit. Dr. Gamini Puncheva was the president of Sri Lanka Orthopaedic Association in the year 2010 and 2011, and he did a human service to uplift our association during that time. It is with great honor I invite Dr. Puncheva to address the gathering.
Good evening. Thank you for the kind introduction, Dr. Bandachiva. President, Sri Lanka Orthopaedic Association, the Council and members of Sri Lanka SLOA, Chief guest tonight, Professor Rajasekaran, Orator, Dr. Dilshan Mundasa, Secretary, Dr. Indika Veerasinghe. Dear friends, ladies and gentlemen, I thank the President and the Council of SLOA for inviting me as the guest of honor for this occasion for the inauguration of 15th Annual Academic Session of Sri Lanka Orthopaedic Association. I am deeply honored and it is a pleasure to be with you this evening. Let me share some of my observations and thoughts with you. I am happy to note and proud that over the recent years, the field of orthopedic care and trauma management has developed tremendously. And senior orthopedic surgeons, present and past, worked hard to maintain the standards of orthopedic care par excellence with the affluent countries. I hope and confident that the young generation will take forward the SLOA and the standard of orthopedics in Sri Lanka to greater heights. We are aware of the numerous hurdles and challenges they face on return from overseas training to practice what is learned. On one hand, they are armed with knowledge, talent, and skills, especially on subspecialties, but feel frustrated when a conducive environment and resources are lacking. Lack of resources such as theatre facilities, or so-called orthopedic dedicated theatres, equipments, including C-arm, orthopedic table, and arthroscopic facilities, are the sort of burning issues we are having at the moment. Work overload, casualty overload, trauma workload, and neglected orthopedics is a sort of a burning problem they are facing at the moment. While it's the responsibility of the Ministry of Health to have a proper plan to provide these, with the current economic crisis, we know how feasible it is. I would like to propose a workable plan with available resources to overcome this until we get a permanent answer. Sharing resources. So new orthopedic surgeons can visit the nearby provincial or teaching hospitals, while the senior orthopedic surgeon can share the theatre time and work with them. So they can do their subspecialties such as spinal deformity correction, arthroscopic surgery, arthroplasty surgery, and tumor surgery are few examples. This will benefit both the surgeons as well as the patients. So seniors can learn from newcomers, and newcomers can learn from experience from the seniors. So I know this is happening even now among few orthopedic surgeons on personal basis. So to make it official, we'll have to change our attitudes. So attitudinal changes in the key to make this possible. The line and provincial health authorities can play a role in support officially providing official arrangements for everybody. It is time to recognize subspecialties as a need of the hour, and the SLOA, Ministry of Health, PGIM is working together to develop a system. The President has already explained to you all about the subspecialty, how are they going to introduce in near future. So this is very important to keep our young surgeons in the country. However, I want to stress that general orthopedics is still the priority. A country like Sri Lanka, so though we are doing specializing on some subspecialties, still the general orthopedics is still the priority. Ladies and gentlemen, well-being of the specialist surgeons working in the periphery is not given due attention, such as providing accommodation. Many has to travel daily, risking their life. So we have very unfortunate experience in the past, risking their life, and so they are not efficient enough to do the work when they are spending a lot of time for traveling. So we'll have to provide some kind of decent travel arrangement, and we'll have to look after their families as well. I know some of the association, so doing some great job of providing school facilities for their children. At the same time, it is to be appreciated that some of our young surgeons have found answer on their own. Fundraising campaigns, building a dedicated orthopedic theatre with local community, with the help of donors and well-wishers, getting equipments from the organizing some kind of private arrangements. I would like to draw your attention to another area. So it is noted that even after perfect fixation, still our patients tend to seek native treatment. Why? Two things come into my mind: lack of proper follow-up and rehabilitation. Maybe due to workload, early discharge to enable new admissions, short stay in the hospitals, and lack of supportive staff. Let us develop a quality, multidisciplinary rehabilitation program accepted to community with the help of community physicians. Up to a certain extent, we can make use of Ayurvedic physicians. So this is, of course, we'll have to handle very carefully. So at the same time, neglected orthopedic an area to focus. Still we'll see a lot of malunion, non-union, and neglected dislocation coming to us every day. So we should not, instead of chasing patient away, the new corrective technique or the techniques will have to modify it in such a way to overcome these problems. With development of ICT, much can be done. Seeking advice from seniors, case-based discussions, sharing knowledge, experience, sharing pictures and investigation. So in a recent development, which bridge the gap. Now we'll have to think about how to move forward. I think we'll have to establish a very comprehensive database to identify magnitude of problem, identify needs and priorities. Sports injuries, MD sports medicine is in place now in Sri Lanka. So therefore, we'll have to recognize sports injuries as a subspecialty in orthopedics. Research, identification of research needs to fill the gaps, provide training in research methodology, conduct operational research. We'll have to introduce to our new surgeons. We'll have to have some exchange training programs for doctors to gain experience and establish links with Center of Excellence. Ladies and gentlemen, in concluding, I wish to pay my tribute to the departed orthopedic surgeons who established the SLOA, taught and guided us to be skilled orthopedic surgeons, humane and united. On a more personal note, I remember Dr. Bandajiva as a silent observer, more like me, with excellent bedside manners and patient-oriented, dedicated training. I started my orthopedic career in teaching hospital Ragama because I am very happy now Dr. Bandajiva is there as a consultant. Without a dedicated theatre at that time, no dedicated ward, no clinics, no staff. I was fortunate that the general surgeons and the anesthetists supported me sharing theatre time, providing beds, even in the professorial unit, clinic spaces, and medical officers to look after, their medical officers to look after orthopedic patients. Within short period, permanent MOs and equipments, implants, all were brought to the Ragama Teaching Hospital from the Ministry of Health. I must thankful to the health officials at that time. So it took very short period to provide everything to the North Colombo Teaching Hospital to establish a new orthopedic unit. However, my dream was to establish a dedicated orthopedic theatre, orthopedic department, and proper rehabilitation unit, but had to come to Colombo. Dr. Bandhujiva has managed to make my dream come true. Thank you so much, Dr. Bandhujiva, for your effortless and your plan to bring this Ragama Teaching Hospital up to this level today. My congratulations to the President, Council of SLOA for their achievement and wish the conference all success. Thank you all for your attention.
Thank you very much, sir, for your well thought out words of encouragement for a collaborative and a sustainable future of Sri Lanka Orthopaedics. And now we have come to another important event. It is a tradition of SLOA to felicitate the immediate past president for the immense service rendered for the betterment of Sri Lanka Orthopaedic Association. The immediate past president for the year 2022 was Dr. Dilshan Munidasa. And now I would like to invite Dr. Bandhujiva Piyasena, President of Sri Lanka Orthopaedic Association, to read the citation and present the President's Medal.
It's a great privilege to read the citation of our immediate past president. He graduated from the Faculty of Medicine, University of Colombo in 1992. After completing his postgraduate training in orthopedic surgery at PGIM Colombo in 2002, he underwent fellowship training in Singapore General Hospital in the departments of sports medicine, trauma and spinal surgery, and arthroplasty surgery. In 2003, he obtained fellowship from Royal College of Surgeons of Edinburgh. Upon return to Sri Lanka, he was appointed as the orthopedic surgeon at the General Hospital, Anuradhapura, in 2003, where he served as the only orthopedic surgeon during the entire period of civilian war in Sri Lanka, managing war casualties. In 2014, he was entrusted with the establishment of a new orthopedic unit at the General Hospital, Gampa, where he served as the first orthopedic surgeon. He is an active member of the AO community in Sri Lanka, and he has helped organize many AO advanced and basic courses since 2015, serving as a chairperson. With his experience, he has also attended many overseas AO courses as a faculty member. He has served as a council member in Sri Lanka Orthopaedic Association and held the positions of secretary. In 2022, he achieved the prestigious position of the presidency of Sri Lanka Orthopaedic Association. Dr. Dilshan Munidasa is currently working as a consultant orthopedic surgeon and the surgeon in charge of sports medical unit at the National Hospital of Sri Lanka. I would cordially invite Dr. Dilshan Munidasa to receive his medal.
Ladies and gentlemen, now we have reached another prestigious moment in the night. That is the felicitation of the candidates who have topped the MD Orthopedic Surgery examination for the year 2023. To give out the awards, I would like to cordially invite Dr. Upali Banagala, Senior Consultant Orthopedic Surgeon, on stage. Our first award, the Dr. Upali Banagala Gold Medal for the Best Student at the MD Orthopedic Surgery Examination, February 2023, awarded to Dr. Podivela Marage Nadun Chandima Marage. Dr. Upali Banagala Gold Medal for the Best Student at the MD Orthopedic Surgery Examination, July 2023, awarded to Dr. Sivakumaran Dishant. Ladies and gentlemen, please give a big round of applause for our gold medalists. Thank you, sir.
Thank you, sir. And now we have reached the academic culmination of the evening. Sri Lanka Orthopaedic Association oration, this time in honor of late Dr. Pradeep Fernando, Senior Consultant Orthopedic Surgeon. To introduce this year's orator and to present the orator's medal, it is my pleasure inviting Dr. Bandhujiva Piyasena, the President of Sri Lanka Orthopaedic Association, again to the podium.
Dignitaries at the head table, dear ladies and gentlemen, it's a great honor to introduce the SLO Orator 2023. Dr. Dilshan Mundasa is the second child of late Mr. and Mrs. T.G. Munidasa of Galle. He received his primary education at St. Aloysius College and Mahinda College in Galle, where he was an active member of athletic, cricket and cadetting teams, and was awarded the prize of the best all-rounder at the school prize giving. In 1984, Dr. Munidasa began his educational journey at the Faculty of Medicine, the University of Colombo, to pursue his passion for medicine. After successfully completing his medical degree, he obtained board certification as a consultant orthopedic surgeon in the year 2003. To further expand his expertise, Dr. Munidasa completed fellowships in sports surgery, spine surgery, trauma, adult reconstructive and arthroplasty services at the Singapore General Hospital in 2002. His dedication to learning and professional development led him to obtain prestigious fellowship at the Royal College of Surgeons of Edinburgh in 2002. Enhancing his skills in the field of orthopedic surgery. During the civil war in Sri Lanka, Dr. Dilshan Munidasa served selflessly as a sole orthopedic surgeon in General Hospital Anuradhapura between 2003 and 2009, caring for the war-injured soldiers as well as civilians. He also established arthroplasty, spine and sports surgical facilities in that hospital. Dr. Dilshan Mundasa's commitment to improving orthopedic care extended to several peripheral hospitals in Sri Lanka, wherever he was appointed as an orthopedic surgeon. In 2014, he was the first orthopedic surgeon to be appointed to General Hospital Gampa, where he was instrumental in starting NIV unit to serve the community of that area. Since 2016, Dr. Mundasa has been making significant contributions in the field of orthopedic surgery at the National Hospital of Sri Lanka. His dedications to advanced orthopedic education is highly commendable. He has served as local course chairperson for AO courses in Sri Lanka for the last 12 years. He has also organized and facilitated the country's first AO advanced course and first non-operative management courses, further enriching the knowledge and the skills of orthopedic trainees. In addition to his clinical and educational roles, Dr. Dishan Mundasa has been an active member of professional organizations. He held the positions of Assistant Secretary of SLOA from 2011 to 2012 and the position of Secretary of SLOA from 2013 to 2014. In 2022, he was selected as the President of SLOA, a position that reflects his dedication and leadership qualities. He also introduced subspecialty societies for orthopedic community during his presidency. The Spine Society and the Arthroplasty Society were established in Sri Lanka during that time. Beyond his clinical and organizational contributions, Dr. Munidasa's expertise is recognized through his role as an examiner in MD Orthopaedics, MD General Surgery, as well as MD Sports Medicine. He actively participates in evaluating and accrediting medical professionals in these fields. Additionally, he serves as a member of Board of Studies, demonstrating his commitment to shaping the future of medical education. On a personal note, Dr. Dishan Mundasa has a brother and a sister. His brother is Dr. Amal Priyantha, a gastroenterologist and a surgeon, and the sister is a teacher. He is married to Dr. Nimini Pereira, a consultant histopathologist, and they are blessed with two daughters, Shamali and Dinuri. Dr. Dishan Mundasa's journey as a consultant orthopedic surgeon, along with his unwavering dedication to the field of medicine and education, makes him an invaluable member of the orthopedic community in Sri Lanka. May I cordially invite Dr. Dishan Mundasa to deliver the SL oration 2023.
Chief Guest, Professor S. Rajashekaram, Guest of Honor, Dr. G.L. Puncheva, the President and the Council of Sri Lanka Orthopaedic Association, past presidents, presidents of other colleges and societies, invited guests, Professor Janaki Hevavisanti, a family member of Dr. Pradeep Fernandu, ladies and gentlemen. Tonight, I am privileged and honored to be in front of you to deliver the oration of Sri Lanka Orthopaedic Association 2023. In this year, for the first time, the SLA oration has been named to honor the memory of Dr. Pradeep Fernandu. Whose remarkable contributions continue to inspire us. Vidanage Pradeep Anthony Fernandu was born on 28th January 1962 to Mr. Clement Fernandu, Hospital Administrator, and Dr. Selva Jyoti Fernandu, general practitioner. As their only child, he enjoyed a childhood devoid of wants and pandered to as most only children are. Pradeep obtained his early education up to grade 9 at St. Peter's College, Vellavatha, where he was model school boy consistently, first in the class and carrying away most of the prizes. On entering Royal College, his personality underwent a marked change where his scholastic achievements were overshadowed by co-curricular activities. He found great joy in English debating, drama and public speaking. His incisive mind and command of the English language enabled him to excel in debating and win the J.R. Javardhana Award for Best Speaker at Royal College. By contrast, in a day-to-day life, Pradeep was always a man of few words, and his dry sense of humor was not understood by many. Pradeep was very successful in advanced level examination, obtaining the best marks in zoology at Royal College of and becoming eligible for selection to the medical school in Colombo. But his mind was set on an education in humanities and law. However, under pressure from his parents, Pradeep reluctantly sent off his application for medicine and entered the Colombo Medical Faculty in 1981. The first 2 years in medical school was boring for him, but the later years were for more successful, and in that he found an ideal study partner who was later became his wife. Together they both graduated with second-class upper divisions at the final examination with distinctions in gynecology and obstetrics, almost identical results exemplifying how closely they had studied together. Pradeep secretly nurtured his love for law and thought forensic medicine would be the ideal choice for his postgraduate career. He was at this point, Dr. Daya Rodrigo, his surgical mentor and guru, strongly advised him to take up surgical career. Pradeep heeded his advice, passing his MS Part 1 at his first attempt in July in 1991, and his MS Part 2 2 years later, and then opting for specialized training in orthopedics. He obtains his overseas training at All Church Hospital, Ramford, under Mr. Lang Stevens, and returned to Sri Lanka to complete his senior registrar training under Dr. Banagala. Dr. Banagala describes Pradeep as a hardworking and dedicated surgeon, contributing immensely to the efficient functioning of the unit. As a consultant orthopedic surgeon, he was first appointed to North Colombo Teaching Hospital, Ragama. During his stay, he worked extremely hard for the benefit of patients with a wide range of orthopedic problems. His untiring efforts to save limbs and lives of young personnel in attending to mass casualties of war was remarkable. Since the time he was appointed to Ragama, he took an initiative to get orthopedic unit approved for the postgraduate training. The current president of SLOI, Dr. Bandhujiva, was his first senior registrar. Thereafter, many trainees from orthopedic, general surgery, and other fields followed. Many leading orthopedics and general surgeons today were his trainees and are testament to his success as a teacher. He was a genuine trainer who guided trainees all aspects of work, be it clinical work, surgery, or scientific writing. He was very tolerant of deficiencies of trainees and reluctant and certified them gladly, taking it as an opportunity rather than a problem. He happily shouldered even the burden of finding overseas training placement for many orthopedic and general surgical trainees. His academic services extended outside the sphere of orthopedics to surgery in general, being a member of Board of Study and examining surgery Part 1 and Part 2. Dr. Pradeep was the Secretary of College of Surgeons of Sri Lanka and editor of Journal of College of Surgeons of Sri Lanka. He not only trained postgraduates, but improved the orthopedic services of North Colombo Teaching Hospital and wards as a key figure in designing the new multi-storied accident and emergency building. Dr. Pradeep Fernando took a keen interest in developing the healthcare system in Sri Lanka and was a live wire in the World Bank-funded health sector development project. He handled much of the project single-handedly and brought in much needed finances to the Orthopaedic Association. He moved to the National Hospital in Colombo in January 2012. He was determined to make a difference and took on the task of training himself on scoliosis surgery. He was also passionate about relieving the mental trauma and much as physical disabilities of those young scoliosis patients. Their gratitude to him during his life and his death was ample testimony of how much he had achieved in short span. He would have contributed immensely to that field had the nature been a bit kinder to him. Pradeep did not wish publicity and never wanted to disclose that he did more than operate on patients. He went to the extent of arranging funds for those who could not afford implants. He established a trust fund to help patients pay for the deposits on external fixators, thereby allowing them to return home for rest and recuperation among their loved ones. Dr. Pradeep Fernand was instrumental in the reactivation of the Sri Lanka Orthopaedic Association in the year 2000. He held a post of secretary from 2000 to 2004, making the association one of the most efficient medical associations in Sri Lanka. He organized the first AO course in Sri Lanka in the year 2000 at the teaching hospital in Ragama. Since then, he organized several AO courses in the country in the association and with an AO International. He was the AO coordinator for Sri Lanka and practiced an AO activities in regional countries as a resource person. He was also a regular attendee and resource person at outreach programs of the SLOA conduct all part of the country. Dr. Pradeep was a council member for a long period and then the vice president of SLOA at the time of his demise. Pradeep was a voracious reader. He was hardly ever seen without a book. He also loved singing. He was family-oriented and adored his only child, Saishna, very much. He often used to spend his leisure time by walking and cycling with his son. Theirs was more friendship similar to that what Dr. Pradeep had with his father. It would be fitting to end this quote from Shakespeare, which would have liked as his epitaph. His life was so gentle, and the elements so mixed in him. The nature might stand up and say, the world, this was a man. Thank you. Now I start the oration.
In honor of Dr. Pradeep Fernando, we would like to invite Prof. Mrs. Janaki Heva Vicente to accept this memento from Dr. Dishan Munidasa.
Good evening. Today, we will be focusing on patellar instability. It's a condition where the patella experience abnormal movement or dislocation. Throughout this presentation, we will cover its causes, symptoms, diagnostics, and selection of right treatment for appropriate pathological condition. At the end, I will present results of a group of patients who underwent surgery for patellar instability. Let us now dive to the fascinating world of patellar instability. Let me start with some statistics. The incidence of primary patellar dislocation is calculated to be around 5.8 per 100,000 population. It is more common in younger age group than old. If an individual dislocates once, there is 15 to 40% chances of dislocation again. As the number of dislocations go higher, the chances of dislocation become more and more. Let us now see some anatomy of patella. The largest sesamoid bone in the body, which develops 7 weeks of gestation. The patella is embedded in the quadriceps tendon. It's flat and has 6 articular surfaces. When the knee is in extension, the apex lies 2 to 4 centimeters proximal to the joint line. Patella stays stable in front of the knee because of multiple ligaments attached to it. Superiorly, the quadriceps tendon, inferiorly, the patella tendon, and on either side, medial and lateral retinacula. The structure which is important for tonight's discussion is the medial patellar femoral ligament, which consists of 3 bands of capsular thickenings, patellotibial, patellomeniscal, and patellofemoral. The medial patellofemoral ligament is the primary restraint to the lateral patellar displacement. It tightens up in full extension and loosens in full flexion. It provides 50 to 60% of the lateral restraint from 0 to 30 degrees of flexion of the knee. The medial patellofemoral ligament is about 55 millimeters long, and the width can be varied from 3 to 30 millimeters. It has a very good tensile strength of 208 newtons. The patella, why patella dislocate? There are many factors, both soft tissue and bony abnormalities, that are responsible for patellar instability. I like to go through these factors and try to elaborate how they are responsible. If I consider the soft tissue structures first, the most important structure is the rupture of the medial patellar retinaculum. Weakness of vastus medialis muscle and tightness of vastus lateralis muscle said to be responsible for patellar instability. However, they are not responsible for primary dislocation. They can be factor of instability after primary dislocation. That is the basis of rehabilitation in non-operative method. Coming to osseous abnormalities. If the patella lies higher than where it should normally lie in the trochlea groove, it can be easily slipped out laterally. We call this patella alta. On a lateral radiograph, taken at 30 degrees of flexion, the height of the patella can be determined. There are 3 parameters that can be used to determine the presence of patella alta. The first one of them is the insult-salvati ratio. Here we compare the length of the patella with the patella tendon length. Patella tendon length being the denominator. If the ratio more than 1.2, patella alta can be diagnosed. In the Caton Deschamps index patellar articular length is compared with the line drawn from the lower end of the articular surface to the anterior lip of the tibial articular surface. Patella alta is diagnosed if the ratio is more than 1.3. In Blackburn-Peel ratio, the length of patella articular surface is compared with another line drawn perpendicular to the lower tip of the patella articular surface to a line drawn parallel to tibial articular surface. The normal value is 0.8. If it is more than 1, patella alta can be diagnosed. If the patella is high, it can be brought down surgically by osteotomizing the tibial tuberosity, taking it down and refixing at a lower point on the anterior tibia. However, this procedure has its own complications of detachment of distal hinge of the osteotomized tuberosity, tubercle fracture, and postoperatively painful hardware. This paper published in 2018, which studied 133 patients who are undergone the patellar tuberosity transfer in combination with medial patellofemoral ligament reconstruction. This study shows that the complication rates were high even when the transfer was combined with additional procedure of augmentation of medial structures. Now we come to another bony pathology that predisposes patellar dislocation. It has been found by Bradstrom in 1966 that shallow trochlea in the knee predisposes the patellar dislocation. We call it trochlear dysplasia. In fact, this pathology has been found that in about 96% of patients with recurrent dislocation of patella. The anterior articular surface of the lateral aspect of the distal femur is higher than medial side, preventing lateral displacement of the patella. In biomechanical studies too, it has been shown that lower degrees of knee flexion, the lateral articular surface of the femur exerts more pressure, acting as a lateral restraint. The normal trochlea has an angle of 142 degrees. If the angle is more than 142 degrees, patella would dislocate easily. The best view to visualize this deformity in the distal femur is patella merchant view. Here the X-ray is taken with knee flexed to 45 degrees and beam is directed to the knee at 30 degrees of angulation. On the lateral X-ray of the knee, crossing sign can be noted in the presence of trochlear dysplasia. Based on combined evaluation of the merchant view and the lateral radiographs, Dijo Laculta has classified the trochlear dysplasia into 4 categories. He recommends higher groups to undergo trochlear deepening procedure. This picture shows how the deformities are visualized in each category in lateral and merchant views. There are surgical procedures to address the shallow trochlea. Trochleoplasty is one of those. Here the knee joint is open, articular surface is incised, and underlying bone is deepened. Articular cartilage is then put back on the bone and reattached using sutures or staples. Trochleoplasty is a very challenging surgical procedure associated with high morbidity. This procedure could give rise intra-articular adhesions post-surgically. Therefore, certain authors have tried MPFL reconstruction in patients with trochlear dysplasia instead of trochleoplasty. From this study, they have found that MPFL reconstruction is a safe procedure to address trochleoplasty. The third common reason for patellar dislocation is the increased distance between the tibial tuberosity and trochlear groove. Unlike other pathologies, this parameter cannot be measured by using X-ray. It could only be appreciated by CT or MRI scan. The normal TT-TG distance is 15 millimeters. This is a CT scan of the knee showing TT-TG distance. On the superimposed view of the tuberosity cut and the cut along the trochlear areas, the distance is measured between the two parallel lines drawn perpendicular to the posterior condyles of the femur. The TT-TG distance is higher when the knee is in valgus. This could be measured by Q angle. The Q angle is the angle between the quadriceps pull and the pull of the patellar tendon. Normally, this value is 10 to 15 degrees. The higher the Q angle, the higher the chances of higher the TT-TG distance, and therefore high chances of dislocation. The surgical procedure to correct this TT-TG distance is to medialize the tuberal tuberosity. This is called medializing osteotomy or Fulkerson's osteotomy. However, this procedure too has its own complications. Delayed healing of the tuberosity osteotomy and anterior skin necrosis are well-known complications. This is a surgical picture of this procedure. We can see amount of dissection and the invasiveness of the procedure. This is reflected in some publications in the international literature. In this study, they have concluded that this procedure has higher complication rates. There is an association of screw size and amount of distillation of the tuberosity with the complication. The fourth bone abnormality that predisposes patellar dislocation is the tilted patella. If the normal individual, in a normal individual, the lateral border of the patella can be brought to the horizontal. Clinically, if that cannot be brought to the horizontal, tilted patella could be diagnosed. Radiologically, in a merchant view X-ray, the tilt angle is defined as the angle subtended by the line joining the two edges of the patella and with the horizontal. However, when the lateral release have been tried on the tilted patella, that has not produced good results. It could be argued that making release of the lateral constraint on the patella in a knee where medial constraints have already been damaged would make the patella even unstable. However, this information is valuable in a patient who had prior dislocation. There is a high chance of failure of conservative management in such patients with tilted patella. Therefore, this information helps us to decide on the MPFL reconstruction at an early stage. There are research evidence to prove that. This paper shows us that lateral release being an effective procedure with combination of medial strengthening procedure, not as a stand-alone procedure. Furthermore, this procedure has been used to address in patients who has no instability. It has been used to address anterior knee pain due to maltracking of patella. We call this lateral patella compression syndrome. There are other abnormalities that could predispose for dislocation other than the four pathologies that we have already described. Internal rotation of the femur is one of those. For an internally rotated knee, lateral pull from the quadriceps could bring dislocation easily. This picture shows intraoperative view of femoral derotation osteotomy being done. Derotation osteotomy surgical procedures are challenging, and those procedures associated with high mobility. This paper published in 2021 shows that even though the procedure corrects deformity effectively, in its comparative study, MPFL reconstruction would be better procedure in recurrent patellar dislocation. Similarly, external tibial rotation too could bring about patellar dislocation. When tibia is rotated externally, the TT-TG distance becomes more. As mentioned earlier, increased TT-TG distance is one of the major determinants, derangement that could bring about patellar dislocation. There are surgical procedures that are done to correct external tibial torsion. However, these are highly complex and associated with high morbidity. like other osteotomy procedures. This is reflected in a recent paper published in 2022. After studying 7 studies, it has been found that even though this procedure could correct the anatomical derangement, the complication rates were high, amounting up to 12.8% at the recurrence, and also the recurrent rate is high. Now let's come to the clinical aspects. How do we assess a patient with patellar dislocation? More precisely, the age of the onset is important, as most instabilities start at younger age. Most patients are young. Now, one should get a proper history of injury mechanism and the status of pain. Whether it is a first-time dislocation or recurrence makes the management difference. It is important to know whether the instability is bilateral, and also if there is a family history, as dislocations runs in families. Patient's activity level is important to decide on the time frame of the management. Prior intervention could make the surgical decision different. When it comes to examination, one should make the patient stand at the beginning and observe overall limb alignment, the gait, foot propagation angle, and position of the patella, making note whether the patella is high, low, tilted, or facing each other, or looking away from each other. Then the Q angle can be measured on a supine position by drawing lines from center of the patella to tibial tuberosity and ASIS. Then the patella tilt test can be performed in a normal individual. As I said before, it can be brought to 0 and up to 20 degrees. Inability to bring patella to horizontal predicts tightness of the lateral structures. While in seated position, the patellar tracking could be observed. Look for abrupt lateral deviation at the terminal extension of the knee. This is called inverted J sign in patellar examination. At 30 degrees of flexion, patella is moved medial and laterally while holding between the index and thumb. If the patella can be mobilized more than 25 degrees, 25% of its transverse width, it can be said the medial structures are deficient. Similarly, if the mobility is less than 25 to the medial side, it can be said that the lateral structures are too tight. Then the patellar apprehension test can be performed on the supine position, taking the patient to the edge of the bed. The patient is pushed to the lateral while bending the knee. The test is positive when the patella shows signs of apprehension. Finally, at the knee, look for effusion, tenderness, and cortical wasting. Then concentrate on limb alignments. As we all know, valgus heel and pronated foot predisposes dislocation. Excessive femoral internal rotation can be observed in the position shown in the image below. This is another deformity which predisposes patellar dislocation. Then the Ober's test is done to assess iliotibial band tightness. Beaten score is important for identifying ligament hyperlaxity patient. The flexibility of joints are observed in 5 different extreme positions, and score can be given out of 9. To assess functional disability before and after surgical procedure, Kujala score is a useful tool. This was developed in 1993 by Dr. Urso Kujala. It is very popular validated scoring system. This is an anterior knee pain score where questionnaire is made on 13 aspects of functional outcome. These are the 13 items on which scores are given, some of which are walking, running, climbing stairs, jumping, etc. The radiological assessment have been already discussed when we discuss about bony pathologies. And about CT and MRI as well when we discuss about TT, TG distance in early part of the discussion. Now we come to management. Management of patellar dislocation can be discussed along two lines: acute primary dislocation and management of recurrent patellar dislocation. Acute primary dislocation. The common mode of dislocation is indirect force. The knee is put into valgus with femur interrotated while the leg fixed on the ground. With strong contraction of the quadriceps at this position, patella can dislocate. Majority of acute dislocations are managed conservatively. After relocating, ice is applied every hour for 24 hours for reduced inflammation. Knees may be aspirated if there is tight effusion or hemarthrosis. Analgesics may be prescribed and the knee may be immobilized for a short period. At the post-acute stage, we could employ taping. This is a very useful technique at OPD setting. Once done, the patient start walking happily. It is better than applying crepe bandage or brace in subacute stage. Those who undergo conservative management after the acute stage should undergo rehabilitation exercises, stepping down, exercise for strengthen the vastus medialis muscle, and core muscle exercises to stabilize posture. Then the patient undergoes further rehabilitation program stepwise. First 2 weeks, 2 to 6 weeks, 6 to 8, and up to 12 weeks. With regards to management of primary patellar dislocation, the International Patellofemoral Study Group has 100% agreement to manage primary dislocation non-operatively, provided there are no significant associated knee injury. They are in 89% agreement to reconstruct the medial patellofemoral ligament primarily in case the patient undergoes surgery for other reasons like osteochondral fracture at the same time. There are certain indications for primary surgery: large osteochondral fracture, loose body, MPFL insertional bone avulsion, and highly unstable patella. This slide shows an avulsion fracture with the attachment of the medial patellar ligament. Several authors have compared the conservative management with surgical management in primary dislocation. The results show that results are comparable. Now, if we operate for associated injuries at primary dislocation, what are we going to do with the medial patellofemoral ligament, either repair or reconstruction? MPFL can be successfully repaired at acute stage if avulsed from the one end. However, MPFL mostly ruptured at two sides and therefore repair often fails. MPFL is better reconstructed than repair. This has been proven in many researches. This is one of the publications. It shows that the repair group had 40% recurrence compared to reconstruction. How do we address recurrent patellar dislocation? Even recurrent patellar dislocation, there is a place for conservative management. Particularly when the dislocation is following severe trauma or when there is no osteochondral fragment associated. Similarly, when the dislocations are isolated or infrequent, when it happens during the ongoing sporting session of a sporting individual, the surgery can be delayed. This has been shown in some management algorithms as well. There are more than 130 surgical procedures have been described for recurrent patellar dislocation. Those could be proximal realignment procedures or distal realignment procedures, depending on the surgery is concentrated on the femur or tibia. We have seen in the early part of the presentation that even though these procedures address the primary pathology, they have high morbidity. Therefore, in recurrent dislocation, we may not address the primary pathology. Rather, we could select some other procedure with low morbidity. The MPFL reconstruction has less morbidity. Therefore, it can be utilized in many pathological conditions. Surgical technique consists of 4 steps: harvest and prepare graft, find isometric point on the femur, femur fixation, and tibial fixation. The graft substitutes can be obtained from the patient's own tissues. The common sites include gracilis, semitendinosus, quadriceps tendon, or adductor tendon. For the patellar anchorage of the ligament, there are various methods. It could be tunnel placed on the medial edge of the patella, or cross tunnel passing from medial to the lateral edge of the patella. And similarly, a suture anchor planted at the medial edge of the patella could be utilized. The most difficult part of the operation is to select femoral anchorage point. To be successful, this point has to be pinpoint accurate. The tibia rotates around the isometric point on the femur. Reproduction of this point intraoperatively is difficult and challenging. Radiologically, this point can be identified in the operating room. X-ray of the perfect lateral view of the femoral condyles. Here, the blue line represents the line drawn along the posterior cortex of the femur. There are 2 lines drawn perpendicular to this line. The red line starts at the posterior end of the blue Pensart line. The orange line is projecting from the transition point between the femoral condyle and the femoral shaft. At surgery, this point can be identified 1 millimeter anterior to posterior cortical projected line and 2.5 millimeter distal to the end of the posterior femoral articular cartilage. Now I present results series of patients who have underwent surgery for patellar instability. In our records, we could find 37 patients who have undergone MPFL reconstruction from 2016 to 2023. Out of 37 patients, only 17 patients were traceable. This group, there were 14 females and 3 males. Mean age at surgery was 28 years. The reason for low number in this group is due to the fact that half the patients who have undergone surgery were not traceable. This is a common occurrence in our country as people keep changing their phone numbers. Had they had dislocations, they would communicate to us first. Therefore, it can be assumed that they had no dislocation. However, they were not considered for the analysis. The other reason is that during the pandemic time in 2021 and 2022, no cases were done. Obviously, people had bigger problems than patellar instability during that period. Mean time since surgery was 31.9 months. Analysis was done using time to recovery, dislocation, or reoperation following surgery. Kujala score was assessed and on traceable patients and tabulated. There are main features in this group. Case selections were done on clinical grounds. All surgeries were performed on patients with chronic instability. All constructions are done with gracilis tendon. MRI and CT scan studies not considered. Medial patellar anchorage is tendon loop through the drill hole, 3.5 millimeters at the medial board of the patella. Radiography has not been used to identify the isometric point. Now I show a short video of how intraoperative video. You can see the patella is highly mobile and not. And first you make a small incision to harvest the tendon at the medial side of the knee, and the sartorius fascia is divided, and the gracilis tendon is isolated and looped, and then stitch is made at the end of the tendon to isolate. And then the end was severed and the tendon stripper is used to harvest the tendon. And it comes with a lot of muscle fibers attached to it, and then we clean it and take off all the muscle fibers and get the tendinous part only. Then we mark the patella. Incision is made on the medial side of the patella. And as we all know, there are 4 layers in the knee. And then we make an incision on the medial side of the patella and open into the space between layer 2 and 3. There's a potential space where we would like to pass the tendon to the femur. And then make a drill hole on the medial side of the patella to pass the tendon. And then we retrieve the tendon. We use the needle to bring the tendon to the outside. It is pushed backwards, and the loop so created is used to get the patella tendon to the gracilis tendon to the other side. Once it is isolated, then we make a stitch to make it a loop. And then in the potential space, we make an incision on the medial side over the medial epicondyle of the femur, and then we pass the artery forceps. We call this railroading. We bring the artery forceps from the opposite side and hold the tendon and bring to the medial side. So the most difficult part is to find the isometric point. The technique used here is to use the pin, and we loop it around and make a small pen mark there and make the knee into flexion and extension movement several times to see whether there is movement. If there is no movement, that is considered to be the isometric point. And then we drill the pin and bring it from the outside on the lateral side of the femur. The next step is to measure the tendon length, because we have the bias screw of 28 millimeters, because tendinous part has to rest in the hole. So we mark the length. The tendinous part that has to be sent into the femur. Then from that point onwards, we suture the tendon. We have to suture the tendinous part that has to be sent inside the medial tunnel. If you have more length, it will not be taught, it cannot be taught to the other side. Usually we drill up a 6 millimeter drill bit. This is the picture how we do it. We can see it is pulled from the lateral side, and the bias screw transfixes the tendon in the tunnel. So you can make it tight by pulling from the opposite side and making. So once that is done, the medial tissues are sutured, and also then sartorius fascia is also closed. So we have, this table shows tabulation of the collected data at the time of surgery, age at the time of surgery, time since surgery, and their involvement of sports were recorded. This group could be considered to have community dislocated, as there were no professional sportsmen in this group. Only was one dislocation noted. This was a redo surgery for congenital or habitual dislocation. 2 other patients had low Kujala scores, as they were still in the phase of recovery. None of them had reoperations. In the analysis, 3 patients were excluded, as I told before, from the Kujalas, as they had they have not completed the rehabilitation time, and the other patient was excluded as she had congenital patellar instability, and this is a revision surgery, and the primary surgery has been done some time before, and it is a failure. The Kujala score is still very low. We compared this group with publication that has analyzed 55 studies. These 55 papers had analyzed 1,777 knees which have undergone surgery for patellar instability. Mean follow-up period is 39 months in pool data group. In this group, it is 31.9 months. Imaging data were not available in 58% of the study, but they have not specified whether it is a MRI or CT. In our group, some of them had MRI, but only the X-ray reviews of the merchant and lateral views were considered. Double bundle tendon graft was used by other authors in 66% of the cases. In pool data, in this study, all were double bundle. Various fixation methods were employed in pool data group. Mostly, they have also used the bone tunnel. In this group, only medial patellar bone tunnel is used. Femoral fixations have been done with interference screw in 83% of the pool data studies. In this group, only the interference screw was used for femoral fixation. If we do compare in a different way the pool data of 55 studies, as far as the case numbers are concerned, this group has half the number of mean total. However, there were few studies which had equal or less number of cases. The reasons for low number in this group have been discussed earlier. Out of all patients, only 1 patient had dislocation. This was a case, as I said, redo surgery. And the Kujala scores were comparable to pool study data, and 85% in the pool data group, and in this study it's 86.8. In conclusions, comparable results with international research studies with regards to age group and case numbers. Comparable outcome noted despite not using intraoperative radiography for Scotus point. Use of gracilis tendon alone has not made any difference of outcome. Medial patellar drill hole technique has not had to increase complication like patellar fracture. Manual selection of isometric point, trying best position at the tendon does not slide over the pin while letting the knee into motion. So it's an alternative technique where radiological facilities are not available. Patellar fracture has not been reported in any of those. MPFL procedure alone is not suitable for congenital habitual dislocation. So the only case that we have done is failure. Full function recovery came after in most of our series patients in 16 weeks of surgery. Let me conclude my presentation saying that patellar instability is salvageable provided we assess them properly and offer them appropriate method of management. Certainly, if surgery is deemed necessary for patellar dislocation, one effective option is medial patellofemoral reconstruction. This procedure can salvage the dislocation while minimizing the risk of associated with more invasive procedures. I hope you enjoyed my presentation. Thank you for listening, and there are some references that I used to in this to make this presentation. And finally, I would like to thank my patients and the ward and theatre staff of surgical units, and my special thank to Dr. Taraka Jayatilga, my senior registrar, who helped me in data collection and preparation of slides. So that comes to the end of my presentation. Thank you.
Thank you, sir, for that comprehensive oration on recurrent patellar dislocations. Now, I cordially invite Dr. Indika Veerasinghe, Secretary, SLOA, to propose the vote of thanks.
Thank you. I have the important task of thanking everybody behind the success of this year's activities. Professor Rajasekaran, our chief guest, Dr. Gabini Puncheva, guest of honor for tonight, Dr. Bandhujiva Piyasena, President of SLOA, council members, my dear sirs and colleagues, and distinguished guests. I consider it a great honor to propose the vote of thanks on behalf of the Council of Sri Lanka Orthopaedic Association. First and foremost, I would like to thank Professor Rajasekaran for accepting the invitation of SLOA to grace the occasion of 15th annual academic sessions in spite of many commitments back home. He has a very important event in the university in 2 days' time. In spite of that, he agreed to be here with us today, and we truly appreciate your commitment to SLOA. Your talk was truly enlightening, and we as an association and country, we have to find the stone of David in the story of David and Goliath. Thank you for those inspiring words and story. Dear Sir, Dr. Gabini Puncheva, it has been an honor to be your trainee and privileged to have you here tonight, gracing the occasion as guest of honor. Your words of wisdom and the advice on way forward to orthopedics is truly appreciated and valuable. I would like to congratulate and thank Dr. Deshan Munidasa for delivering the prestigious SLOA oration in honor of late Dr. Pradeep Fernando. It was a fitting tribute to Dr. Pradeep Fernando, who has rendered an invaluable service to orthopedics in Sri Lanka. I would like to express my sincere gratitude to presidents and members of all colleges and associations who are here today, and we appreciate the help extended to SLOA to conduct various academic activities. In keeping with the theme of stability and growth in uncertain times, we were able to conduct numerous academic activities all throughout the year. I would like to thank all local and foreign faculty members of workshops, masterclass, live operative sessions, and CME lectures who contributed in various ways. The knowledge and experience shared by these faculty members during the academic events have benefited many trainees as well as consultants. I'd like to thank the consultant anesthetists, hospital directors, and theatre staff of National Hospital of Sri Lanka, Lady Ridgeway Hospital for Children, and King's Hospital Colombo for the fantastic support given for the live operative workshops, Sorbonne workshops, as well as the clubfoot workshop which was held in these venues. I'd like to also thank Director of DGH Monaragala and the nursing sisters for helping to conduct the outreach program in Monaragala district for the benefit of medical officers and nurses. I'm also grateful to Professor Hemali Gunasekara, Head of Department of Anatomy, Professor DJ Anthony, Department of Anatomy, Faculty of Medicine, University of Colombo, for the valuable support in obtaining and conducting the cadaveric spine course this year. I also appreciate Professor Varuni Tennakon, Head of Department of Anatomy, Dr. Sajit Edirsingha, and Professor Harsha Disanayaka from the Faculty of Medicine, Medical Sciences, University of Sri Jawadharapura for the cooperation in obtaining cadavers and the venue for the 2 cadaveric workshops we had in there. We are extremely thankful to all the local faculty, to all faculty of foreign and local of the annual academic sessions 2023, who in the next 2 days will enlighten us and update our knowledge and understanding on various subspecialties of orthopedics. I'd like to thank Professor Nandadeva Samarasekara, President of College of Surgeons of Sri Lanka, Secretary Professor Sanjeev Sinaratna, and the staff of College of Surgeons for providing the venue and for numerous CME lectures, as well as for the New Year celebration program which we conducted this year. I need to thank a few people who have gone beyond their duty to help SLOA activities. Mr. Richard Papile and Mr. Hasita Hangama for the persistent support extended to the SLOA over the years to conduct many educational events like the Distance Education Program, AO workshops, Sorbonne and Cadaver workshops. Also, Mr. Nishan Pereira, Mr. Devmin Karunaratna, Mr. Kalum Pereira, and the entire crew at Zodiac who have supported academic activities all year had deserved special mention. Also, Mr. Prashant Vaningasurya and his team comprising of Mrs. Subhashini Patinayaka, Mr. Anand Thakkar, and Mr. Abbas for actively supporting many activities this year. And Mr. Prem Padmanathan for bearing the responsibility of all the printing tasks of the SLOA annual sessions. I'd like to thank Mr. Sadanandan and his team, Mr. Hansan Koralge, Mr. Sanjay, and Mr. Saravanan for the help in organizing the inauguration ceremony so successfully. I wish to thank our compeers, Dr. Nidan Pereira and Dr. Senith Peramuna, for the excellent work in presenting the event to the audience. All these academic activities have become a reality and success thanks to our generous sponsors who have supported SLOA all year, namely our diamond sponsors, Zodiac Medicals, Zimmer Biomet International, MediSurge International, AOSIS, Avenir Pharma, CIC Healthcare, Medtronics, Axia, and Oppo. Our gold sponsors, Vincit Surgicare, Dyna, Med Solutions, Sandoz Zenat, Renata, Orthofix, Disuta Medical, Hardic International, Harriers Medical, Martin Doe, Avenir Pharma, and SCT. Our store sponsors, Helion, Truvic, Calbe International, Ipca Laboratories, Ortho Lanka, BioLife Pharmaceuticals, AJ Medichem, George Stewart, Zydus Cadila, Searle Pakistan, Pharma Evo, Cipla, Cloud Healthcare, Orion Pharmaceuticals, Genbock Pharmaceuticals, Ascend Meditech, George Stewart Health, Getz Pharma, Surgi Pharma, Dr. Reddy's, Emergent Life Sciences, and Bombay Ortho. I'd like to thank the staff of this excellent venue, Cinnamon Grand, especially Mr. Clifford David, for complying with our numerous requests and providing a great service and atmosphere. I wish to thank our event management team of Mr. Champika Vincent, Mr. Ishara Kapuat of AR Tours and Events, who have done a wonderful job of organizing this event. I also want to thank Mrs. Himasha Vijayatilaka, our office coordinator, for making sure that the SLOA events run smoothly all year. I would like to especially mention the persistent support and dedication of Dr. Devaka Ratnapala, our dynamic Assistant Secretary of SLOA during this year's activities. Also, the significant contribution of Dr. Parakrama Dharmaratna in preparing the academic program and the academic sessions of this year is greatly appreciated. On behalf of the members of SLOA, I'd like to thank Dr. Bandujiva Piyasena, the President of Sri Lanka Orthopaedic Association, for his vision, enthusiasm, and guidance to complete a successful calendar year of activities. I wish to thank the Council and all members of Sri Lanka Orthopaedic Association who have kept its legacy and contributed towards the upliftment of orthopedics in Sri Lanka. Thank you very much.
Thank you very much. Thank you very much, sir. And ladies and gentlemen, as the last official event of today's evening, I invite you all to be mesmerized by the soothing melodies of our young star of Sri Lankan music, Miss Natasha Nirmani.
Thank you, Ms. Nirmani, for that mesmerizing performance. Ladies and gentlemen, that concludes our events for tonight. I would like to thank all of you for your presence. And I also take this opportunity to invite all of you for fellowship and cocktails just outside the hall. There is also a photo booth available outside. You can go wild and have fun with it. Thank you and good night. Please rise for the ceremonial procession to leave the hall.